Hello, 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 hello. I have Miss LaFontaine, help me out. LaFontaine, Miss Johnson, Miss Linder. Did I get your name right? LaFontaine, help me out.
Ludia, it's Ludia LaFontaine.
Ludia LaFontaine. French?
Yes.
Awesome, awesome. Welcome, welcome, welcome. And we have one more minute and we'll officially get started with our exam one review. I also teach community health for the Friday class, and my class just ended here. So we may see some other faces come in. Okay. Looks like we have Teresa, Tracy, Linda joining us. We may have some more. This is not mandatory, but definitely highly recommended for us. And it is 6 o'clock and we're recording. So good evening. I am, for those who don't know me, I am Professor Jennifer Harrison-Hauer. I am one of the instructors for community health. And this is the exam one review. So thank you for joining me on this Friday evening. It's 6 p.m. here in Arizona. So welcome. It's going to be interactive. We're going to go over, I'll be admitting some folks here. We'll be going over something, the PowerPoint, making sure we go over some concepts and help make sure you guys are successful for your first exam, which is next week during your class. All right, so first thing I'm gonna do is share my screen. All right, can everyone see my screen? If you can't, let me know. If you can see it, that's what we're aiming for. All right, let me go to from the beginning. All righty. Excellent, excellent, excellent. All right, you guys. So we have some folks that are joining. And again, I'm Professor Jennifer Harrison-Hauer. This is exam one review. All right, let's get started here. We've got several things to cover. So when you, what do you look for when you evaluate the community? So as a community health nurse, let me just admit someone here. As a community health nurse, you are going to want to get to know your community. That goes without saying. You have to build trust in your community. You want to know you want to know the status of your community. That's where community assessments come in. And you're focusing on preventative health behaviors. So population health is the health status of a defined population of an individuals, including the distribution of health status within the group. So think when you first enter a community, you want to know everything about it so that you can focus on primary, secondary, and tertiary prevention on different levels. So think assessment. What is the issue with the community? And every community looks different. So you want to get to know the community that you're trying to help. So let's see here. All righty. And so one of the big issues that you'll need to remember is that as a community health nurse, and as a nurse in general, you are the advocate for your community. So you're not thinking individual, you're focusing on the community as a whole. So you're the advocate. And then you have to keep in mind that everyone has a right for self-determination. You want to review ethical issues, and then you want to keep in mind that, competent or not, that they have a right to self-determination. And that, and remember that we as nurses are mandated reporters, and that if you see issues in the community, and you will see issues in the community, that you want to, if you witness abuse or what have you, that you're mandated to report it. Because you'll, when you go out into the homes, you'll, you know, out in the community, you'll see things. And so keep that in mind as well. And that your primary focus of community-based nursing, in comparison to your, when you're doing med surg or on your floor, is that is the care of ill individuals and families across the lifespan. So if you're in a home and you have someone, you have babies in the house, or you have elders, you have teenagers, or what have you, that's what you're looking at, is the health and the wholeness of that community unit. When you're looking at community-based nursing, you're looking at managing chronic conditions. And then the primary focus on community nursing is the health of that unit. One second, let me admit some folks into the room. So keep in mind some key concepts here that are bolded. You want to focus on knowing your ethical issues related to abuse and screenings. Community-based nursing is the care of ill individuals and families across the lifespan. And then your community-oriented nursing is on the healthcare of individual families and communities. So then when you're focusing on community-oriented nursing, you want to evaluate the risk of individual families and group. So a lot of this maybe is memorizing definitions, and that's perfectly fine. But just know what they are. And so what we were talking about today in my class, and you guys, I'm hoping to have covered, is that if you are familiar with, very comfortable with the differences between primary, secondary, and tertiary prevention, as a whole, you should do fine. So Linda, give me an example of primary prevention, for example. What are you, what's, when you think primary, what comes to mind? No wrong answers. This is why this is a review.
Primary, the patient doesn't have the disease, so they're preventing it from coming.
Yeah, he is preventing. Yeah. There's no tricks here. Yeah, I am a stickler for trying to remember like key things. Welcome back, Miss Lyons. And then, so disease is not occurring in primary. All right. I am well. I am trying to prevent. So then I am educating folks. I am providing education. I am providing immunizations. No disease is occurring at this particular stage in my in primary. If I'm focusing on primary, I'm not talking about someone that has a health condition. Primary prevent. You're going to educate, you're going to immunize, nothing is occurring. Secondary, Miss Russell, what comes to mind?
Screenings.
Miss Bledsoe, what comes to mind? If I said your name correctly, if not, please correct me. Screenings?
Yes, ma'am. What about a colonoscopy to screen for colon cancer?
Right. Screenings.
Mammograms.
All are correct. Not just screenings, you're doing surveillance, you're you're detecting. So disease is not occurred at secondary also. All right. But the difference between the primary and the secondary is the primary is you're preventing through education, and immunizations are huge. And secondary, you're trying to detect, you're looking for, you're doing surveillance, you're doing those screenings. What about the tertiary, Ms. Nichols? When you think of tertiary, what comes to mind?
To me, tertiary is like treatments on the disease, which would not further harm the patient.
Mm-hmm. They have the disease. So that's really, really, really key things for you guys to remember. That would be, so if you were to, there's a scenario, and I think I mentioned this earlier in my class a few moments ago, where someone has a condition. Diabetes seems to be really big as far as testing goes, not saying that it will be on there, but they have an issue. They have a health condition. So what your goal is that you're helping them to manage their condition to prevent further mortality and morbidity, which is complications of their diabetes, preventing end-stage renal disease and the like. So then if there's a condition that exists, then it has to be tertiary, not secondary or primary. So that's could be an easy way to try to differentiate between all of this. All right, good job, everyone. All righty, and then let me just make sure, okay. I'm just making sure that I have everyone in the group. All right, so we're moving on. So Medicaid versus Medicare. When I think of the way I remember this years ago, when I had to first learn this, is that when I think of care, I think of caring for the elderly. All right, I know all of it is care. And when I think of Medicaid, I think of a Band-Aid. That's, that could be a way for to remember or not, or you can just memorize. So Medicare is to help those 65 and older. Think of your baby booming generations, that baby boomers that are approaching this age. Think of Medicaid as helps low income, and then those who are unable to work, those that are disabled. And so you're looking at the private and the public aspect of the healthcare system. Is broken into two systems, your private being your primary care, your public being your Medicare and your Medicaid programs. So just kind of keep that in mind as well. Another, just to read off, just make sure I'm covering my notes here. Another significant problem has been poor access to healthcare. The American healthcare system is described as two class system, private and public. People with insurance or those who can personally pay for healthcare are viewed as receiving superior care. If you can pay for it, that's the view. Doesn't necessarily mean it is true. Those who receive lower quality care are those whose only, whose only source of care depends on the public funding. The working poor who do not qualify for public funds, either because they make too much money or they to qualify because they are undocumented or what have you. So as you can see, healthcare in the United States has always been just this huge gap of those that have and those who do not, and those that are in the middle who don't have the primary care, private insurance, your Blue Cross, your Blue Shield, and they can't qualify for the Medicaid or the Medicare. So it's something to consider. So the Affordable Care Act, has everyone heard of the Affordable Care Act before this class? All right. And so when you think of the Affordable Care Act, it was passed to help, pretty much to help those I think of in the middle, the ones that don't have the private insurance, those who do not qualify for their either not of age for the Medicare, and they don't qualify for the Medicaid. And so the Affordable Care Act was passed to help more Americans have access to health care, just pure and simple. And then when you look at the fact that United States, as far as if you compare our healthcare to the world, I don't know if anyone's ever lived overseas or in another country. Has anyone else lived in another country and can talk about healthcare in that area? Some places I know when I've done medical mission trips, it's like you have to, there's no insurance. You pay everything out of pocket, or your family pays for anything. Has anyone else ever lived overseas and can attest to that as well, or in another country to where the healthcare system is vastly different than what we have here?
I mean, I know in Haiti, there's no emergency room. It's like if you're sick, you have to have the money to pay for it. If not, you're not gonna receive care.
Right. Anyone else? Yeah. All of this is true. So we are fortunate, but in a country to where we are one of the richest nations in the world, our health indicators, mortality, infant mortality, maternal mortality could be better. So that's what that last little bit is saying, that as well. We could do better with some of our health indicators, absolutely, for sure. So acts to help with public health. The slide is a little bit busy, but let me just get through it here. When you, Federal Medical Leave, Family Medical Leave Act, have most of us possibly heard of it or used it before. It's acts to help the public. Family Medical Leave Act it's really made advances from the first time I've heard of it. Has anyone ever used FMLA? You don't have to tell me details about it's pretty amazing if you've ever needed to care for an elderly parent. Most of the times we think of FMLA after you have a kid, but there are other situations to where you can, sometimes paid, sometimes not, but it is a federal law that is there to help the public. And then your American Disabilities Act, just be aware of that, is pretty self-explanatory. And it's listed there for you as far as it was established in 1990 and what have you. Be aware of that. Shouldn't be any trip ups there. QSIN, the Quality and Safety Education for Nurses, is not federally moderated. This is to help improve, when I think of it, is to help improve what we do as nurses. Is quality improvement, is evidence-based. You want to, the 1, 2, 3, 4, 5 things that are listed there, you want to commit these to memory and just know them. When you think of QSIN, the best thing to do is just to try to memorize. It helps with quality improvement of the quality of care that nurses provide. It's evidence-based. There's computer and informatics involved in it as well. All of this is to help patient-centered care provide the best possible care that we can as nurses to our patients. So keep that in mind and remember it. So when you think of evidence-based practice, no matter what definition of evidence-based practice, is supported, what counts is that evidence has been an issue most hotly debated. If you look here, there's a hierarchy of evidence ranked in order of decreasing importance and use, and has been accepted by many health professionals. I know myself, Whenever I have a patient or client coming in to talk about something new, something hot, something they want me to do for them as a nurse practitioner, I'm like the movie Jerry Maguire, show me the evidence. Don't bring me anything from Wiki. Because with any profession that you're in, let's just say you decide to be a chemo nurse, you want to stay on top of the evidence. There's always research going on something, somewhere, somehow. And you want to subscribe to journals. You have your free library here with the school. But anyway, the point of this slide is that you're double blinded, which means no one knows, the participants don't know what's a placebo, what's not a placebo. You're double blinded, randomized, randomly people are put into categories. Your double blinded, randomized controlled trial is ranked as the highest level of evidence, okay? Just keep that in mind. That is like the gold standard if you're going to do clinical research. There's other types of studies that are listed here for you. Not every study is going to be a randomized, double-blinded, controlled. It's just not feasible. It's not set up that way, and that's fine. Just know that that is that's the gold standard as far as research is concerned. And I would just be familiar with the studies that are listed here. Let me just kind of move over for a second because my battery is dying. You guys still with me? Plugging up my battery here. Can you guys still see me?
Yep, we're still here.
Plugging it up in the kitchen. Here we go. All right, so that's what you just want to know that as well. And then as far as your health disparities, your vulnerable population, again, we talked a little bit about this in my class today as well. So Ms. Russell, when you're thinking of vulnerable populations, what comes to mind for you?
Rural communities that don't have much access.
Okay, yeah, there's no wrong answer. What about Linda? What comes to mind for you?
For people that don't have access to good health care.
Yeah. Everything, this slide is pretty busy, but just keep this in mind. To pull from this slide, when you think of social determinants of health, there are conditions in which people are born, they grow, they live, they work, and age that shape their health. They include factors such as economic status that's listed here, education, where, do you understand the information? Are you health literate? Your neighborhood, are you in a high crime infested area? Physical environment, nutrition, are you getting enough food to eat? Are you stressed because you live in a war zone area? Do you have a job? Do you have social support, folks to help you manage your disease? All of those things can negatively impact your health, especially those that are already vulnerable. So when you think of your nursing interventions, they're designed to help your vulnerable populations. Well, when you think of nursing interventions for this group, you want to get those resources that they need in place to improve their health outcome and reduce their risk of their risk factors. So on exams, you want to, when you see this, think the big picture, I guess is what I'm trying to say. Everything that's listed here is important to be aware of, and just know that. All right, you're looking at the big picture, and you're looking at how to decrease their risk and improve their overall health. So vulnerable populations, again, here we go. So then when you think of your vulnerable populations, there are usually there's a subgroup. There are a subgroup of individuals in our community, not just what you think of the homeless or what have you, or folks that live in a certain in a crime infested neighborhood or what have you. So there are a subgroup of the population that's more likely to develop health problems as a result of exposure to a risk factor. So then you consider the risk factors there when you, as a community health person, when you go out and you see that there's a lot of homes that are older and they have lead paint, or when you do your assessment of the community, you notice there's a lot of crime, there's a lot of murders, there's a lot of theft, there's a lot of car break-ins, there's a lot of violence. And then what about diet? Are there grocery stores nearby? Do they have a place to exercise? We talked a little bit about the case study earlier, Ms. Lyons, and then your biological and genetic makeup of the group. So if you're dealing with vulnerable populations in your community and they have risk factors tied to it, well, that's going to definitely put them at risk for developing a number of health problems and issues, and they're just trying to get by. So what does public health do? Well, by now, from our readings, we should have a pretty good idea. If not, you definitely should have gotten a glimpse of the Healthy People 2030 as well. And so when you're thinking about the public, what does public health do? Number one, our primary goal is prevention of disease and disability. We live by that primary, secondary, and primary triangle. We try to live in the primary as much as we can, but if you're already coming into an area in your community and they're dealing with a high rate of diabetes, well, you just got a lot to work with, but you don't want to, give up on it. You just want them to keep their kidneys and their eyes and their feet and their toes. But we focus on independence, and with the public health nurse, we have a lot of, I work as a public health nurse, we have a lot of autonomy. You're out there in the community, and then you're focusing on your population. You're getting to know them. You're getting to know their families. You're getting to know what they're at risk for. You're doing your research. So you're focusing on all of that in your day-to-day practice. We have policies and standards that guide us to help, again, decrease communicable disease outbreaks, that sort of thing. And just keeping in mind that the leading cause of mortality used to be, back in the 1900s, people died from Spanish flu and all that kind of stuff and what have you. Now it's heart disease and cancer. Both of my parents passed away of cancer, different types of cancer, but they did. Don't got me, I'm not too nervous about it, but it's concerning. So it's chronic diseases. You don't remember the last time somebody died of, pertussis? They could, or, measles. They used to, before vaccines and what have you. They used to die of, somebody sneezed on you. So then again, the population of the world is increasing due to increased fertility rates and decreased mortality rates. So that means people are living longer in comparison to past trends. They're living longer, but they also are living longer with chronic conditions. So they're living longer, but what's the quality of that? So health disparities, let me just make sure I get everything here. The largest is largely impacted by economics, which is money, the number of chronic conditions that's being dealt with in a certain area, and vulnerable populations that are being, negatively impacted by all of this as well. So then, all of the healthy peoples from the first time I remembered healthy people to 2020, 2030, what have you, where they change every decade or so, or what have you. The goal is that we want people to live healthy lives. So there's goals and national standards that are in place, regardless if you live in New York State or if you live in West Virginia, that we want for the entire nation. There are 5 things that are listed here that's of focus for our review. So you would want to know these: healthy lives, free of disease, disability, and injury. We can dream. Lower or get away from health disparities. Create healthy social, political, and economic environments. Everybody to be in a healthy environment, healthy behaviors, well-being, and have your leaders, those who have power and control to make things happen, focus on policies to make us all healthy and being well. So those are things I would definitely know. So then, shifting to the family, when you think of the family unit, the family structure, it's changed over time. You have, as you see in the picture here, you have same-sex families, your traditional family. Grandma could be the lead family member for her grandchildren, what have you. So just know that when you go into a home, if you're a community health nurse, it may look totally different than what you envisioned or thought it should look like, and that's okay. That's their family unit. It's perfectly fine. So then when you're looking at let me see here, functional versus dysfunctional. Ms. Russell, what does a dysfunctional family unit, if you were to walk into a home, how would that look for you?
Dysfunctional.
It's okay. So
I think if it were to be kind of chaotic,
okay, I'll
like
take
if it was sort of obvious that maybe children or the elderly members of the family were clearly not cared for the best way they could be.
Very good. Miss Mason?
Same concept, I would believe. Maybe, yeah, same thing that the other students said pretty much. You would see like elder abuse, or maybe a lot of incidents with a baby, a lot of maybe bruising and stuff.
Okay. So Miss Linder, what would a functional family, how would that look for you? If you were walking in doing a community assessment, you're sitting down, what things would you observe?
I think I would absorb, I would see a family getting along. They would, I don't know, I always picture a family sitting down at a table. They respect, care for one another.
Absolutely. The number one thing that sticks out for me is whenever I used to go out into the homes, I would just sit down, of course, introduce myself and all of that. Let them know why I'm here. Sometimes it's a referral. I'm always open and honest, but I just let people talk. I just talk and I listen. And that's a good nursing thing to do. Just sometimes folks will just give you everything you need to know. Just let them talk or what have you. But I'm watching, I'm looking, and I see myself doing that now. Like even in my classroom, I'm looking and I'm monitoring, and I'm just assessing folks without even doing it or what have you. Communication for me stands out. I'm looking at how they're communicating with each other. What's the dynamic? I look at side eyes and close eyes and straight eyes and all of that, body language. I'm looking at this, looking at this, I'm looking at this, I'm looking at twitches without even knowing it. But as far as, for me, A family that's functional, they communicate, they talk, they don't look funny when somebody walks into the room, and you can like that sort of thing. They communicate with each other, opposed to dysfunctional. There's chaos, there's chaotic, and what have you. Some of it is like clear cut, like, ugh. And then some of it is subtle. It's that silence sometimes too, the way, the way that people present themselves when they walk in. They're overbearing, they're protective, or they're not letting the person talk. They're answering for them, or there's a list. There's an exhaustive list, but just be aware of that. They should be able to communicate with each other with appropriately, with no raised voices. So when you're thinking about characteristics are healthy, okay. As far as prioritizing nursing interventions, I always think of ABCs all day long: airway, breathing, circulation. You're going to see the patient that's having issues, or in your home, the community that has an issue with any of those. When you prioritize, opposed to not saying that mental health is not important, but just when you think of priorities, prioritizing, when you're looking at the exams, just think of ABCs. And then as far as delegation, you do not delegate your education. You do that yourself. Your assessment, your teaching, your evaluation. You don't delegate that away to someone else to do, if that makes sense. If I'm educating my community, if I'm doing the assessments, and then I'm documenting and charting that. If I'm teaching, I am doing that, and I'm documenting, and I'm going back and evaluating. So those are things you can't delegate to a CNA to go out to Ms. Nichols' house. You got a referral, community health referral, and just tell me how she doing. You got to do that yourself. All right.
Professor Harrison, for someone to have community nursing, does it require a referral from like a physician or something, or?
Most of the times, so not everything requires a referral. When I was a public health nurse, community health nurse, public health nurse, interchangeable. I could run a report on all my children my babies that were behind on their immunizations, and I would make surprise visits. I get referrals too. We would get referrals all day long. Someone has syphilis. You can get, so not everything, a welfare check, a pregnant woman hasn't come in for 3 of her visits. Us moms know that that's very important. So there's, again, right. So the answer to your question is that I like to do surprise visits, not all the time, because I don't want them to think that I'm watching them. But I remember I had a family once to where their child was like 9 months and hadn't had a single shot. Not a single shot. I know, close your mouth, it's gonna fly, it's gonna get in there. And so you have to go in, whenever you go into these rooms, whenever you see something, you're like, you have to develop that face and that look. You can't just come out and say, where is your child? I'm gonna call, because that is some areas that's reportable neglect. You can make a case for that, but I don't want to digress for that as well. I mean, if you have something documented that it was religious, you don't, but so I'm just assuming the worst. Anyway, so no, I don't need, that's one thing I loved about it. They would know me. I'm like, where is Miss Bledsoe's house again? The public health nurse came by. So no referral is needed.
I also have a quick question if I can.
No, sure. Go ahead.
So going back to the delegation and prioritization when it comes to family, you said the priority would be ABCs. Which ABC are you talking about? Airway, breathing, circulation?
I apologize. Yeah.
Oh,
Right.
okay. I thought it was a
When you're
different.
prioritizing in general, honestly.
Oh, okay.
When I think prioritization, when we want to instill upon you, airway, breathing, circulation.
Okay.
Just think ABCs, okay, when you're going out in the community. It can be anything from clean air, what's going on with the air quality, what's going on with, again, if you have a family of diabetics, is there smoking in the home? Think when you're prioritizing where you're going to go and what you're going to do, sort of thing. If I was a public health nurse and I had someone that missed their diabetic appointment, and then I had a child that hasn't had shots in 9 months since they were ever, then I'm going to go to that 9-month baby's house because I know that he's going to be vulnerable and at risk for a whole bunch of diseases, especially if we have a pertussis outbreak. So when we had a pertussis outbreak on a reservation, I could literally pull all my kids that were behind in their immunizations, and that would be my focus, opposed to someone who had a diabetic foot ulcer and missed their appointment. We would get all kinds of stuff. So then that's what I would, if I had I don't know, if you had a list of who you might see, it may not necessarily fall on airway, breathing, and circulation. It might not say that, but then I would think who would be more at risk, who would I see first on my list, sort of thing. Who's the most vulnerable? Maybe that's the best way to put it when you prioritize. Who's the most vulnerable? You can think of it from your ABC standpoint, whatever makes sense for you. But you can always think of your primary, secondary, and tertiary as well as prioritizing. Okay, so genomes and ecomaps. When you're thinking of genomes, you're thinking of the genetic makeup, genetic design. What's always used to say, especially back home when I work in a university, my lingo would change with who I'm working with. I'm like, know what's in your genes and know what's in your genes. So know your genetic tree, and that's good to know as well, especially if you're in a community where there's a family history of this. And then when you're looking at, just change up your ecomaps, just think of your family connections with other social units is listing there. So you're looking at the church, the schools, the clubs, and what have you. What's the flow of the energy? Is it positive? Is it negative? An eco map represents the family's interaction with other groups and organizations. So the genomes is more personal about what's going on in your genetic family that could put you at risk. You know, I was the last sibling of my siblings to be put on high blood pressure. I fought it in my 30s, 40s. I'm in my 50s, fought it. And I said, you know, it is what it is. All right. So just know those concepts. Yes, please. Ooh.
No, I apologize. So genomes is more personal, and then you said ecomaps is
So
more broad?
yeah. So your genomes is your genetic makeup. Just look at that last little blip. And it's good to know that when you do an assessment of your community, especially if there's, if that community or that family dynamic has a high rate or high number of folks that have colon cancer or hypertension, as far as I would say, how are you going to do your interventions and where to kind of, all of this is trying to figure out in a family crisis where you're going to start. When a family is not able to cope with an event, it becomes disorganized or dysfunctional, and they say they can't do this. You're gathering all of this information so you can help them, persuade them of what's needed to help with that condition. So genomes is your genetic makeup, and then your eco maps is, I think of, I don't know, ecological environment, what have you, their relationships with others. And all of this, again, in my culture, church is huge. So that might, if I don't have family, church is my family. My soror club, that might be my family. who's going to help me out with this. It may not necessarily be someone in your genome or your genetic makeup. That's good to know. Genomes is good to know what's in your genetic tree. Ecomaps is to provide information about relationships. So now that we know what's in the genetic makeup, she has this social unit available to help her to manage this. So they're two separate. So if you have a family in crisis, you want to kind of break things down. Genomes is to know more about their genetic makeup. Ecomaps is to know more about their relationship with others. The family, of course, but everything in the social unit. So all of this is like you're nitpicking their community apart and figuring out stuff. And I know it seems like it's a lot, but when you're a community health nurse, you want to have, there's no information that's too small. And you might think, well, oh, the hospital's easier. No, the stress here, stress there, stress. I actually enjoyed it being outside of the hospital. I did. So anyway. So then your home visit. So again, all of this, now you're at the house. Sometimes they smile at you, sometimes you don't. The key to all of this, I have conducted many health visits. Look at, anytime in these slides you see bold stuff, you may just, it's bold for a reason, okay? Trust, whether you're in the community, at the bedside, you guys have all been to doctor's offices, different places to where you're like, I may or may not be back to this clinic. You know, the front desk person, this or that or the other. If you don't trust, then it's going to be pretty hard for someone to take any of your primary, secondary, tertiary. They're not going to want to listen to you. They don't trust you. That's anything in any relationship. So community health nursing is a relationship. You are a visitor in their community. You are a guest when you come to their house. So keep that in mind as well. When I would go into the homes, I would just look, I wouldn't make it so obvious, but I would see, you know, how the cords were running all over the place, the rugs, so people can trip and fall, but I'm not gonna call them out on it. I'm just making note. So before the assessment, that's another thing that's bold here. You wanna know why, I think Ms. Lyons was saying, why you're there to begin with, okay? Doesn't have to be, no one has to tell you to go out. I think that's what I wanted to say, Ms. Lyons, to a home. If you know your community, and it takes time. You can, one of my biggest things I would do is every quarter I would have a reminder come on my computer to run my immunizations. I would send out letters, and then I would give it a month, see if they made appointments. So it's like, and it's never ending. And then folks that were like behind, especially if you're dealing with, we've had pertussis outbreaks, we've had Rocky Mountain spotted fever. There's no immunization for that, but I'm just saying we've had outbreaks before. Measles, when I got there, we had a syphilis outbreak. CDC was actually on the reservation. So the point is that there's different levels, but if I need to come and knock on your door, I will do it with so much respect and love, but I have no shame. I will go out there if a kid's 9 months hadn't had a shot, and I'll bring immunizations with me. But again, I don't want to, let's stick to this slide. So they say, yes, let me go ahead. And it's flu season. I would have flu shots with me too. You know, I can give you your flu shot. I can. You even need to come into the office. I got you. Roll up your arm. All right. So then we need to review the age-related concerns. So just know you may see scenarios or questions about infants, infant focus, children, or adolescent focus. And just know that you may see something about SIDS. So when you think of SIDS, Roxanne, what does SIDS stand for?
I am not exactly what it stands for, but I know it's related to the babies. Sudden infant death syndrome, that's what it is.
No, it's okay.
Trying to
You didn't
think
correct me.
about
Every
it.
once in a while, I'm just gonna see if y'all with me. That's okay. It's late. I know it's late. So then, and then two big things that they have listed here, 2 words, SID, sudden infant death syndrome, and abuse. So those are 2 age-related concerns for your infants. So you gotta think, okay, what have I heard? Back to sleep. Okay, so I'm educating on that. No soft mattresses, no broken pacifiers, no blankets. That's why, they always, you see the babies are swaddled. And these are things you learn. You don't have to memorize, but again, no teddy bears, no thick blankets. All of this has been shown when they've done research as far as the no smoking in the house and no teddy bears have been found. Research has been done anecdotally that children that died of SIDS, there was instances, there were smoking, and it's late. There were cases to where the parents smoked in a home or someone smoked in a home. They were on soft mattresses. So that's why a lot of these times they're educating on this, because it's been found in majority of cases of SIDS. And then abuse, of course, that's mandatory reporting, and that goes without saying. So as far as when you're talking about abuse, you're looking at, I would say, keep in mind that, of course, abuse can occur from 0 to 99, but as far as infants are concerned, usually you find from 3 months to about a year. When they're born, they can't, they're not turning over, they really can't get into trouble. I don't know if that's the word I want to use or what have you. When they're becoming more active and the parents are crying more and they're crawling more, and they actually have to, do more with your kid who's not just sleeping and you're changing the diaper. They have found that abuse tends to occur higher in infants from 3 to a year. Doesn't mean it can't occur any other time, but just something to keep in mind. All right. So then for your children, you want to know environmental things you should look for when you're assessing common areas like playgrounds. What's the quality of the equipment? What's putting them at risk? Always prioritize your interventions, safety and recommendations. Focus on, again, I think ABCs, airway, breathing, circulation. You can think primary, secondary, tertiary. If you're at a playground and you notice that the equipment is dilapidated, broken, what have you, then these are things you just want. A lot of things that you're doing is all about prevention and awareness. How long should you swaddle a baby? Up to what age? I don't know if there's a certain age where you stop swaddling a baby. I don't know if that's an age-related thing. I would say that if if you're swaddling someone that's 9 months old, that's just not going to work. That defeats the purpose of it. You're always going to do back to sleep. But if I had to take a gander up until the first 2 to 3 months, maybe, it depends on how mobile they are. If you're swaddling a newborn, they're not all over the place. So that's the whole point. And that way you don't need necessarily extra blankets and stuff in there, because that's the whole point of swaddling. You're mimicking them feeling comfortable as if they're in the womb. And then let me just make sure I don't forget anything here. And then your children that have chronic illnesses, they have a medical home, whether at the pediatrician's office. So that's important to know, that children can have chronic illnesses. Asthma is a chronic condition. And so they have a medical home, and as a public health nurse, one of the things you want to know, you don't need to memorize all this, but if someone has a chronic condition, they have a medical home, and you want to have that person's information in case you need to contact them about something, that doctor's office. So just know that. And then car safety for adolescents, seat belts and what have you. Remember, primary, secondary, tertiary prevention. If you remember what those are, what they mean, then if you ever get a question where they're asking you about that, just go back to your primary, secondary, tertiary prevention definitions and like, oh, okay, I got this. Let's see here. So then risk assessments. You know, as far as, I mean, this is a slide that talks, obviously it talks about gun safety, your drugs and alcohol. The big piece for here to remember is that even with my kids, we had conversations at an early age about drugs and alcohol and guns. And so when you remember you're a guest in someone's home, it's all in how you present it. You know, where's your gun? Let me see it. You don't need to, no, you'll get kicked out. Probably not kicked out, but asked not to come back into their home before or what have you. But you do want to educate about gun safety. Oh, you guys have a gun in the house, huh? Oh, okay. Is it, you have it locked? I'm sure you have it locked, one of those big old fancy locks or something. If not, you need to educate them on that. And then we'll just go back. They do not, the children do not need to know, the teenager, where that gun is, locked or unlocked. So then that's another thing you need to just be aware of. It's all about reducing someone's risk. Of course, you're like, oh, no guns in the home, but people have guns. It's nothing, I want to get into the whole gun laws and all of that stuff. They can legally own a gun, educate them on making sure that it is safe for away from people in the home. We've all heard in the news and read in the news about a teenager child accidentally shooting somebody, this, that, and the other. So that's your whole thing. You might think, oh, community health is just talk. Well, a lot of it is education. You know, educating people on how to properly take their medications. I'll just digress. I had a patient years ago when I was started as a nurse practitioner. Don't laugh, but she put her birth control pill in her down there. I know. You got to work on that look, Miss Ludia. I know I didn't say your name right, but it's just, I know you would think, I would never do, oh, I've done some things. I'm like, oh my goodness, no one ever told me. But anyway, so education is huge. Primary, prevent, nothing has occurred. Immunizations, think education. If you had to remember two little things from each section, P, prevent, immunization, education. S, secondary, screening, surveillance, mammogram, colonoscopy. That's pretty much easy. No disease. I always like to think early detection. Let me see if I can find something. Tertiary, they have something. And what do I need to do to help them prevent further complications from high blood pressure, stroke, heart attacks, diabetes, lose a kidney, dialysis. I don't want that to happen to them. Lose their eyes, lose their foot, lose their toe, amputate this, amputate that. So just know that when you have a disease in tertiary, you always educate your patients, regardless community healthy or not, nursing or not. I hope you're not just like, take your Tylenol. I've known folks to be allergic to acetaminophen. You know, I've known folks to overdose on Tylenol. I've known folks that the other. So you're always educating. But once you have something, you don't go back to primary with that. Not trying to confuse anyone. You have it. So now we're trying to hope you live the best life possible with your cancer. Okay, let me see here. And so we talked a little bit today about school health nursing in my particular group, Friday group. They're not just boo-boos and covering fallen people that skint their knee or what have you. They are the community health nurse for that particular school. They probably know more about your child than, or your child probably talks to them more than, about certain things. So think again, it's always primary, secondary, tertiary. They're teaching, they're doing screenings, they're doing immunizations, they're giving nebulizer treatments to the child who's having wheezing or what have you. They may even, I'm sure, follow up with that mom always, but they call the doctor's office. They like, hey, can you consider this for this person's asthma? I think we need another inhaler. You advocate. So again, they treat emergency medical treatments. We know, everybody knows that, but folks don't realize they are huge on injury prevention and they are huge on reducing risk as far as obesity is concerned and teens and nicotine are concerned. So they do a lot of teaching and education as well. And then guys are doing great, hanging in there. As far as the ethical laws are concerned, just know that you have you're always going to be, hopefully not every day, presented with moral dilemmas, and that can sometimes maybe test your morals and your character. Who do you see first? What do you do? And so you just have to remember that you always want to be ethical, and ethical means that you're doing things according to standard, and that you're communicating, and that you're working within your scope, and that you're not doing anything unethical in how you take care of your patient, if that makes sense. As far as the Nurse Practice Act is concerned, every state, I have licenses in different states. Some states as a nurse practitioner have more autonomy. In Arizona, we do. Some states, like Florida, where I'm from, I don't. Just know what you can and cannot do for your scope as a future RN or what have you. So if you're in whatever state, you need to just know, because there's several times I've said, that's not in my scope. I do not do lumbar punctures. Could I do one? I've seen them done, but I love my license. I've had a consistent, nice license since 1994. I started as an LPN. I know my place. So just know that the Nurse Practice Act is there to protect the public by setting qualifications for what we state by state of what we can and cannot do and what have you, but it protects you as well. So just know that as well. It protects them, your patients, but it protects you and your license that you work really, 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 really hard for. So just know that. And then that is all as far as our slides are concerned. All right, ladies, I'm still charging my laptop. I'm opening up to questions. Miss Russell, Miss Bledsoe, Miss Nichols, Miss Lyons, Miss Alexis, Miss LaFont. Help me, say it one more time. LaFontant. Yes. Can you guys not hear me now? No?
Nope, we can hear you.
I can
Okay,
hear you.
I just
I
was
can
trying
hear
to
you.
pronounce the name again and I think I slaughtered it. I'm gonna stop. So that concludes the slide presentation of what I was to cover with you guys today. All of the reviews, we have the same information as far as what we're somebody's over your shoulder, Ms. Nichols, is that as a ghost? It's not a ghost.
Sorry, it was my boyfriend. Sorry.
You don't have to, no, I have to apologize. I was just like, I am going to church on Sunday. Okay.
With her
next question.
background blurred, it kind of looked like.
Yes,
"Ooh."
thank you, Ms. Lyons. I can always
Yes.
tell. I'm like, I was
Oh, it
hoping you were gonna
does.
say it
It
because,
was kind of crazy. Yeah.
no, ladies, this is, you know, this is your time. What specific questions? Ms. Lyons is in my cohort for Friday. Everybody's lecture style is a little bit different, but the information is the information. Anything I can help to clarify for you or something that I'll try to answer best I can.
Yeah, I got a question. All right. So
Okay.
when it comes to select all that applies, what questions would fall under that category to have an idea?
So who's talking right now?
Miss Mason.
Miss who?
Mason, Unixa?
Oh, I don't see you. Oh, you're on your phone.
No, I got you. You could see me. I got you.
Oh, okay. No, so, okay. No. So no, it threw me off. No, say that again, probably a little bit slower.
No problem. All right. So when it comes to select all that applies, when it comes to the exam, can you have give us an idea of what questions will fall in that category?
Oh, all that applies? Oh, I would have no idea because I don't have access to your test. You're trying to trick me.
No, never.
No. I mean, I will say, you know, I don't, and it would be unethical for me to give you an example. Okay, but I will say this about all that applies. Yes, that's a possibility that you may or may not have a question that says all that applies. I always say this. When you read the scenario, okay, you should be able to, if they give you a list, remember Ms. Lyons in our thing today, they should give you a list of a bunch of stuff, possible answers, okay? You should be able to knock out, if it's all that applies, and you can knock out a couple easily, then it's not all that applies. If that makes sense. And I'm not trying to trip you up. So you already know it's not all that applies. If you're like, this just can't be it. So keep that in mind. I don't know if that helps or not, and maybe it does, and maybe it doesn't.
Can I just share one thing that helps me with the select all that apply?
Sure. Yeah.
So when I read the question and I know that I'm answering a select all that apply, I first read it without looking at any of the answers twice so that I can understand really what the question is asking. And then I'll look at the answers and I will phrase them in like a true or a false scenario. And then I've learned through trial and error not to change my answers. If I just go with my first answer or my gut instinct, that's usually the correct answer. But on the select all that apply, maybe that's what's helped me, is to just read one of the answers and say, is this a true statement or a false statement? If it's true, then I select it and move on.
And then too, so everybody has their test taking strategies. If you're not prepared, and I know it seems like, then you're going to get tripped up easily. You should be at a point to where nothing can phase you. And I know, this is just the second week and there's tons of stuff to digest, but I literally, in my little busy world, have listened to every single recording, and I don't have to. but I have, because I'm like, oh, that's good, let me add that. Oh, that's good, let me add this. Oh, I'm gonna make sure, because that's why I keep looking at my notes and looking at my notes and looking at my notes, because I know this stuff, but it's how you present it will help. So if you're able to answer when you look at the chapter objectives and you can answer that if someone gave you that question, like, I know what that means. I know that in your text, like if you click on like the blue link, it'll give you the definition, but you have to get to the point where you know, like again, after Miss Lyons has spent an hour and 40 minutes with me and then this, and if I ask her primary and she can't tell me what primary, I'm putting you on point that I have not done my job and she has not done her job. And it's a team effort. So then I can't give you an example because I don't know your quiz, but it should be to the point to where they can't trip you up. And if you're not comfortable with that, then you need to go back to do your readings and what have you, seriously. Because there's, I know that there are 50 questions, and I do know that there will be a variety of different things. So don't automatically think all that applies and that's the answer, and it's not, and you're like, oh man, you know, what have you. If you're able to eliminate, then it's one thing, then it's not all that applies. And that's your answer. Next question. I'm looking for my note, but I can't find it. Next question. It was nice meeting you too. We're done with our you guys don't let me keep you any longer than I have to. The review has ended. I've gone through the slides. If there are any questions, I'm happy to stay on and answer them.
Should we write our names in the chat?
Yes, please. I see everyone's name. I see everyone's first and last name. Is that, oh, yes. I don't know how to say that. Oh, let me try. Yanexa, help me.
Yeah.
Really?
Close enough. Yeah, that was good.
No, that's not how do you say it.
It's Unixa.
Huh?
Unixa.
Unixa. What derivative is that name from? What? Unixa.
It's made up.
Oh, okay. So you can.
No, it's pretty though. I really
No, it
like
is.
it.
I was
It's
thinking
really
in
pretty.
Spanish.
Yeah, I like it.
Basque.
Yeah, my mom's Cuban, so it's definitely Spanish.
My daughter's Cuban. Her father was born
Oh.
and raised in Cuba. No hablas
Awesome.
español.
Yeah, my name is very unique.
Yeah, that's why I was trying to make the Y or J, and then I totally slaughtered Le Fatante. I love it, but I know she just gonna nod, but she knows I'm not saying it right. All right, I will wait till everyone exits off. Thank you so much, and
Thank
good
you.
luck. Take your time, know your basic concepts. I promise you, we are not here to trip you up. Have an amazing week.
Awesome. Thank you.
Thank you so much.
You're welcome.
Have a good night.
You too.
Do we need to put our professor's name?
Bye-bye. Huh? What was it?
Do we need to put our professor's name?
No, because it's not, it's not a required, but you can if you want to, but no, you
Okay.
don't have to. Yeah, because you don't
Okay.
get like extra credit or anything of that nature, but
Okay.
hopefully you get like 100% and do amazing. Have a good weekend, Miss Christie, Miss Roxana.
you.
Unless you have any questions, I'll wait
Thank
till you
you.
exit out. Thank you so much, my dear.
Thank you.
Nice
Nice meeting you.
dear. You too. Maybe I'll see you around.
Just one quick question.
Yeah. Go
You
ahead,
know how,
Christy.
yes, okay. One of the questions that I have is like, you know how when you say for a tertiary, after you do okay, so tertiary is basically you have the disease.
Yes.
You say that you have to go back to primary?
No. And I should not have, I didn't want to trip you up. So if you have a disease, then you're not going back. If you have tertiary, you're not going back to primary. So you don't go backwards with that. So if you have cancer, okay, then you're living in tertiary, period. Even
No,
if
but you were saying that, okay, for tertiary, it's like teaching, it's teaching of the fact that the person has a disease, but you don't want to, but
it's
you
not
don't want
primary if they have something.
Yeah, so that's why I'm trying to I'm putting the concepts together because it's like,
Okay. let me go over it. Let me go over it my way a little bit different. So the only one that has anything to do with somebody has a disease is tertiary, period. So if they mention anything on the exam and somebody has diabetes, it's automatically tertiary. Automatically tertiary. Primary, you don't have a thing. Secondary, you don't have a thing. Tertiary, you have something. So then if it's the easiest one for me is tertiary because they have something. All right. So if they have asthma, then you're managing that tertiary you're managing it on a tertiary level, but they have something. So primary, secondary, and tertiary has to do with primary. The disease does not exist. You're educating them on it, or you're giving them a vaccine so they don't get it, or hopefully don't get it. So you're talking about the importance of getting your flu shot every year, or you're talking about the importance of something, but you're educating or you're giving them a vaccine. I remember those two things. So no disease. Secondary, no disease. You're doing a mammogram to see if you can find something. So that's a screening. You're doing a surveillance, which means that you're monitoring the trends, but they still don't have anything. It's the action. So it's all about what you're doing. It's the action that you're doing. So you still don't have anything secondary, all right? But you're doing the S's. You're doing a surveillance, you're monitoring, you're doing screenings, okay? Tertiary, you done found something. They got breast cancer now. Now you got to help them live the best they can with this. So your focus is on getting them to their chemo, getting them to their radiation. It's more rehab or what have you, but that's the only one to where they have a condition and you're managing it at that time.
Okay, I got it. Okay.
I know you got it.
All right.
I know you got it. I think your boyfriend waiting for you.
My boyfriend's still here.
Okay. Okay.